She's a 63-year-old female, KPS 90, first presented in January 2020 with left-sided weakness. So her first pre-op MRI brain was done with contrast on January 2020. So this is the her initial MRI brain done 2020. I'd like radiology to comment on these scans, please.
जी Samvik. So I went through the case. Actually, the images provided are very limited. So I only have sagittal T2, and then I have post-contrast axial and in axial and sagittal planes. I don't have a plane T1 to look at the initial characteristics which are before contrast. So what I can see on sagittal T2 images that there is a solid cum cystic lesion. The cystic component is hyperintense on T2. It is in the midline above the corpus callosum, and it has an interior solid T2 hypointense component, which is probably showing that it has a dense cell packing. I cannot appreciate on this that it is intraaxial or extraaxial. There is associated interior vasogenic edema, which we can see in the third image in this row. And go back to the go please go forward, go to the next image. So when I looked at the axial T1 post contrast images, it is lying in the midline centered on the fox, so it appears to be extra axial because it is showing extension bilaterally along the fox. The T2 hypointense component anteriorly is showing post contrast enhancement, I'm assuming, because I don't have the pre-contrast T1, so I'm assuming that it was low on or hypointense on T1 plane images. So it is basically possibly a dural based extra-axial midline lesion showing extension bilaterally displacing the brain parenchyma and has a cystic cum solid uh, internal texture. And on T1 post-contrast sagittal images, the same features are, re-demonstrated. So to me, this is an extra-axial lesion because it is displacing both of the cerebral hemispheres and it is lying along the fox and so it does not appear to be a meningioma because it has heterogeneous characteristics. The age group is 65, so I was just considering about hemangiopericytoma in this case because it has inhomogeneous texture.
All right,
That's all
thank you.
from my
All right, thank you. So this was her initial pre-op MRI. After that, she underwent energy-guided resection of the right parasagittal lesion. Her first post-op MRI brain was done with contrast. So this is her post-op MRI. Can the radiologist please comment on this scan?
Yes, so on the post-contrast MRI, I can see further heterogeneity in the lesion. The cystic component appears to be decompressed. There are possibly blood products in the surgical bed which are giving this heterogeneity. There is a craniotomy flap in the right occipital region. And do we have post-contrast? Yes, so on post-contrast T1 weighted images, again, I don't have a pre-contrast, so I don't know how much of this is blood because the blood products, they have certain signal characteristics on T1 and T2 weighted images. So possibly there are some blood products as well as there is some residual solid component. Cystic component shows decompression, but I mean, we need to compare it with plain T1. On sagittal T1 post-contrast images, there is a small solid residual component in the surgical bed, and then there are post-surgical changes in the scalp. There are few blood products possibly. There is some enhancement in the surgical bed, which appears to be reactive. Secondary to post-surgical changes, there is some dural thickening, and that's it. So these are coronal FLAIR images, and on coronal FLAIR images, I can see that there is some pathological edema in the surgical bed, secondary to post-surgical changes, and there is no cystic component again. The changes are centered along the dura bilaterally in both cerebral hemispheres.
All right, thank you. So on histopathology, it came out to be solitary fibrous tumor, WHO grade 2. MRI brain with contrast was repeated again in May 2020. So this was a scan done in May 2020. Can the radiologist please comment on the scan? Thank you.
So what was the date of the first scan? January 2020, right?
Yes, surgery was done in January 2020, and the prior scan that we were discussing, that was also in January. And
So
this
it is
is the
4 months. It is 4 to 5 months apart, right?
yes, exactly.
Okay, so in the new scan on P2 weighted images, we can appreciate that there is a heterogeneous signal intensity region, which is showing
Çok Ahmet gördü. Abi gördü.
You got muted.
डॉक्टर शुमाइला म्यूट हो गई हैं।
Okay, can you hear me?
यस यस
Okay. So there are some T2 hemosiderin blood-related products secondary to post-surgical changes on the T2 weighted images, which we can appreciate in the middle image. And there seems to be some associated solid component as well. But for that, I would like to look at the post-contrast images. So on post-contrast images, there is subtle enhancement, not very significant. There is possibly some residual, but there are associated, associated dural thickening. There is interval regression as compared to January. Very minimal solid component, absence of cystic component, probably a very tiny cystic component on the left side in centrum semi-ovale. So there is significant interval regression secondary to surgery with some tiny residual solid component and minimal hemosiderin products. Here's some sagittal. This is not T2 axial. This is sagittal T1 post contrast. It is labeled incorrectly. So the same findings which we saw on axial post contrast. These are T1 weighted sagittal post gadolinium images. These are coronal FLAIR images. This is not T2 axial. These are coronal FLAIR images because we can see that CSF is showing suppression. There is some residual edema, pathological residual edema. The edema shows significant interval decrease as compared to the initial post-op FLAIR images. So that's all I can appreciate.
All right, thank you. So she was advised radiation in 2020, considering the residual disease, but she was non-compliant. Then she presented with a worsening left-sided weakness in July 2025. So her MRI brain was repeated again. So this was the pre-second op MRI brain with contrast done in July 2025. So this is the MRI. Can we discuss this, please?
So if we consider the previous images from May 2020 over an interval of 5 years, On T1, as it is labeled that these are T1 post-gadolinium images, there is significant interval increase in the size of lesion in the surgical bed, and it is almost like many times doubled in its size. It is more on the right of midline, and it is again adjacent to dura. It is reaching up to the occipital horn of right lateral ventricle, and there is some component on the left of midline as well. So it is showing significant interval increase. The same thing is seen on sagittal post-contrast T1 weighted images. So the lesion has significantly increased in size. So this is the same. I mean, this is from the same set, or is it from a different date?
Yes, Dr. Shumala, it's the same MRI.
Okay, so in this we have sagittal T1 post contrast, and then we have sagittal T2 weighted images, and we can appreciate that the lesion is very heterogeneous. It has T2 weighted hyperintense areas, that is a cystic component. It has dense solid a component which has dense cell packing, which is T2 hypo-intense, and there are multiple areas which are showing enhancement. The cystic areas are showing peripheral enhancement, so that points to the heterogeneity of the lesion. Then the lesion is causing significant compression as well as crossing through the corpus callosum. So possibly it appears to be it was initially extraaxial, but now it seems that it is infiltrating the brain parenchyma, because we can appreciate especially the last image in the last row, which are T2 weighted sagittal images, in which we can appreciate the corpus callosum, and we can see that in the distal half of body of corpus callosum, the signals are different from rest of that. So there is significant interval increase in the size of the lesion as compared to the previous scans with heterogeneous texture. And what else I can see? Yes, that's all I can see.
So thank you. She again underwent surgery, and this was the post-second op MRI brain with contrast. So this was after the second surgery. Can the radiologist please comment on this scan?
Can I know that what is the time interval between surgery and this scan? What is the exact timeline you people follow for post-op MRI? Is it an immediate post-op MRI or
जी
a
डॉक्टर
delayed one?
जी डॉक्टर Shumala, we do it within first 72 hours, and most of the
Okay.
scans were done in 24 to 48 hours. ये
Okay.
एक ही केस है डॉक्टर Maha?
Yes, Dr. Essen,
Yes.
and this MRI was done, I think, within 24 hours.
Okay.
Okay, so we can read. There was vasogenic edema in the previous images as well, which I forgot to mention in the sagittal T2 weighted images and these flare images. So we can appreciate on these T2 weighted axial images that there is uh, the lesion which had increased in size. Most of it is resected, but there is still some heterogeneous solid looking component. There are few blood products which appear as T2 hypointense rim. There is an area of vasogenic edema on the right side in the centrum semiovale, and then there is some component which was lying in the line of ventricle is still probably not resected. It was too deep to reach, and on the first image you can see heterogeneous post-operative changes. Do we have post-contrast? Yes. Also on post-contrast, we can see that most of the lesion is resected. There are few T1 hyperintense areas which can probably be hemorrhagic products. There is some solid component still lying, which is deep-seated adjacent to the ventricle, because it is still causing mass effect on the right-sided lateral ventricle. And we have then enhancement. Okay, the first one was pre-contrast T1, the previous one which we saw, and the T1 hyperintense signals in that were probably the blood products. And now in this we can see that along the along the outer lining of the lesion, we can still appreciate that there is some enhancement. On the right side, there is some residual solid component, but most of the lesion is resected, but there is still some lying in the surgical bed. There are post-surgical changes in the scalp tissue. There is some residual peripheral enhancement. The most enhancing component is along the anterior and lateral aspect, close to the ventricle. And most of the lesions is resected, but the margins of the lesion still show nodularity and enhancement. We can appreciate pathological vasogenic edema around the lesion, more so in the right cerebral hemisphere. There is some lesion, some component of the lesion along the left of the fox, and that's all. So basically, the solitary fibrous tumor is a hemangiopericytoma. It's the new name given to hemangiopericytoma.
Yes, so on histopathology, it again came out to be solitary fibrous tumor WHO grade 2. And our query was regarding further management of this patient. Thank you.
Thank you, Dr. Ma'am, for the case presentation. So, because as Dr. mentioned by Dr. Shweta, these cases were previously labeled as perimeniocytoma. Right now, it is more toward the solitary fibrous tumor. So, when you're talking about the solitary fibrous tumor, so the first thing that need to be checked is that whether it is because of the true CNS presentation of the solitary fibrous tumor, or it is coming out from outside, so there is some evidence outside the body as well. So Dr. Mahamu, could you please check whether there is any staging workup being was done for this patient as well?
Yes, Dr. Hassan, for the staging workup of this patient, a CT neck, chest, abdomen, and pelvis was done, and it came out to be negative.
Okay, thank you, thank you. So, because solitary fibrous tumor is a grade 2 recurrent disease, so definitely this patient require adjuvant radiation therapy. This patient was offered radiation therapy previously as well, but she didn't opt at that time. But now, because it's a recurrent disease and with some enhancement as well, I would actually recommend adjuvant radiation therapy for this patient. Dr. Mother, would you like to add something?
सर म्यूट हैं सर, आप प्लीज अनम्यूट. सर यू स्टिल म्यूट, सॉरी.
हाँ, ये भी आ रही है आवाज?
जी आ रही है सर.
हाँ, इसमें ये कि 2020 में जब इसकी सर्जरी हुई थी, आप लोगों ने कहा था कि पेशेंट वो नॉन कंप्लायंट और शायद रेडिएशन नहीं लगी या कुछ लगी, आई डोंट नो एट दैट, कि कुछ छोड़ के चली गई. आई थिंक दैट वाज द टाइम ऑफ कोविड, मे बी शी डिडंट रिसीव रेडिएशन, maybe she just had few fraction, I'm not sure, वो डाटा देखना पड़ेगा. But otherwise 5 साल गुजर गए, she definitely need radiation because this tumor recurred and it came back double the size. आप कह रहे हैं कि इसका size बढ़ गया था, and so adjuvant radiation की definitely इसमें ज़रूरत है. And also it depends on her performance status. If she has a good performance status, she is fit and up and about, definitely radiation should be offered.
Thank you. Because previously when she was present in 2022, she was offered radiation therapy, but somehow the patient didn't herself opt for radiation therapy because of the because she has some concern at that time. So
Okay,
she
so
didn't
उस वक्त radiation लगी नहीं थी.
नहीं
So I
नहीं
think
लगी
now
थी.
one can plan radical radiation to this
जी
patient,
बिल्कुल.
because this is the only chance for her now. Leaving her again, this will if she lives जितना भी होगा, it will recur again. So it's better to radiate her within
And
6
sir,
weeks of surgery.
And sir, when you say radical radiation, can you please elaborate a little bit for
देखिए जो रेडिएशन की
participants?
डोजेज हैं ब्रेन में इट वेरीज फ्रॉम 54 ग्रे टू 60 ग्रे सो अगर ऐसे ऑर्गन एट रिस्क हो वहाँ पे जहाँ पे ऑप्टिक क्याज्मा या तो उसमें हम 54 ग्रे से ज़्यादा नहीं जाते हैं अगर ऑप्टिक नर्व आ रही है वहाँ पे हम डोज रिस्ट्रिक्शन में 54 ग्रे की रखते हैं अदरवाइज रेडिकल रेडिएशन नॉर्मली इज फॉर हाई ग्रेड ट्यूमर्स इज 60 ग्रे एंड 30 फ्रैक्शंस अदरवाइज शी कैन हैव अब डिपेंड करता है जब उसके वो ऑर्गन एड्रेस बीच में बनेंगे और उनको फिर ये डोज कंस्ट्रेंट दी जाएगी नॉट मैक्सिमम देन 54 ग्रे तो डेफिनेट है लेकिन 60 ग्रे तक भी जा सकते हैं
And in these cases, you would not go for SRS?
No, SRS is only given to very small tumors और वो हम तब देते हैं ब्रेन ट्यूमर्स में एसआरएस का प्राइमरी ब्रेन ट्यूमर्स में एसआरएस का कोई रोल नहीं है मेटास्टैटिक में ज़्यादा रोल है और वो लीजन्स शुड डिपेंड 5 लीजन्स तक की जा सकती है एसआरएस बट उनका साइज और वॉल्यूम मैटर करता है लेकिन नॉट फॉर द ब्रेन ट्यूमर उसमें एसआरएस का नहीं वो क्योंकि इट्स अ वेरी हाई डोज ऑफ रेडिएशन मच मोर हायर देन व्हाट आई वाज रिकमेंडिंग एंड वो बहुत छोटे एरिया को दी जाती है बड़े एरिया को नहीं इसमें तो अडीमा भी है यू हैव टू कवर ऑल दैट अडीमा एंड ऑल दैट एरिया तो इसमें एसआरएस का कोई रोल नहीं है
So I just want to add, Dr. Hassan, on the just what yes, Dr. Mazhar said, because one of the things that goes for radical doses, you consider 54 to 60 or 59.40, depending upon the dose recognition you have choose for that particular case. So because in this particular patient, there is some enhancement along the resection cavity, we cannot totally rule out or more towards some residual diseases. So I would more incline towards the higher side of doses, provided it alternate risk allow us to actually proceed with that thing. The other thing is that for solitary fibrous tumor or the brain tumor, usually in the upfront setting, I totally agree with Dr. Mazat, there is no as such a role of stereotactic radiation therapy because it all depends upon the volume, looking at the size of the tumor previously in the pre-op setting as well as with the post-op setting and considering the extent of the resection cavity and also the residual disease and the flare changes, the volume would be too big for considering points of technical. It is not a currently the standard of care. The standard of care is that you need to proceed with the conventional fractionation radiation therapy in the form of IMRT or VMAC to conform it as much as possible, but without losing the local control.
Thank you, sir. Because most of our participants here, I think they're from neurosurgery. I think this information is important because in my clinic also a lot of patients ask me about, what kind of radiation and all these things. So ideally, they should be referred to the radiation oncologist, but to have this simple information can help us a lot navigate through these patients. So thank you for that discussion. Any other
So,
thing? Yes, sir.
so Dr. Munib is also with us. Dr. Munib, would you like to add something in the discussion?
Thank you, Dr. Asim. Can you hear me?
जी आ रही है आवाज डॉक्टर मलिक
जी जी I totally agree with what Dr. Mazhar has said and Dr. Asim has commented. Adjuvant radiation should be offered to this patient because it is behaving like an aggressive tumor. Or the doses up to 60 gray should be offered to this patient or 59.4 gray at 1.8 gray per fraction. But the other thing is that regarding the SRS part, totally agree with the comment because most of the patients they got the information from the messages, social media, and other platforms that radiosurgery or some type of machine is beneficial. No, the indication should be remembered, especially the neurosurgeon because these patients are presented to the neurosurgery team first. इसमें ये कि जो metastatic lesions हैं, brain metastasis है, SRS is preferred choice for those lesions. और AVM और benign tumors, small meningiomas, pituitary adenomas, उसमें हम जो कि very small tumor, less than 3 centimeter कट ऑफ हम याद कर सकते हैं इसको to make it simpler. इसमें इंडिकेशन है रेडियो सर्जरी की. अदरवाइज जो है जो प्राइमरी ब्रेन ट्यूमर्स हैं उसमें देयर इज नो इंडिकेशन रेडियो सर्जरी अनलेस इट्स अ रिकरेंट डिजीज जो कि स्मॉल ट्यूमर्स होते हैं उसमें कंसीडर किया जा सकता है. That's all. Thank you.
Thank you, Dr. Manib.
So
And
one thing, one thing
please,
more.
yes,
If
sir.
so, any do we have any medical oncologist or Dr. Mother can actually comment on any role of systemic treatment in this particular case apart from
I
radiation
I
therapy?
I don't think केस में कीमोथेरेपी की इंडिकेशन है because chemotherapy normally we would give for high grade tumors or anaplastic tumors. इसमें I don't think there's indication for chemotherapy in this particular case.
Thank you, Dr. Mother. Yes, Dr. Hassan, you are saying something.
The same question I wanted to ask कि अगर कोई कीमोथेरेपी भी हम इनको ऑफर कर सकते हैं या नहीं. And sir, do you prescribe these patients with this kind of vasogenic edema to start some steroids अपनी therapy के दौरान?
Yes, definitely. Steroid should be started before starting radiation because radiation can cause brain edema और वो एकदम से मरीज को fits पड़ते हैं. They have lot of vomiting or headache. So steroid should be started. We normally start them with high dose and then gradually taper it off. During the course of radiation, it should be gradually tapered off but not stopped. And then after completion of radiation, it should be again gradually tapered off. But radiation के साथ brain edema होता है and definitely this patient should be started on DEXA along with PPI cover.
Perfect. Thank you. Okay. Dr. Asim, sorry, you were saying something.
Yeah, so our practices here is that we also follow the same thing for larger lesion having clear changes or edema. We usually add dexamethasone along with the radiation therapy. However, for small tumors or don't have so much edema, we usually start with the radiation therapy plus don't. And if the patient requires steroid support during the treatment, then we can add. The other thing is that because majority of the patients who come to us after surgical excision already have on anti-epileptic, so with that portion is already covered in the epileptic medication as well. So considering all these factors together, we have to decide individually if which patient require radiation steroid during the radiation therapy or not. But I agree with Dr. Mother that it has to be incorporated if it is required.
Great. Thank you.
So one of the important things that I would like to actually highlight that previously that I also asked with Dr. Maham during the presentation regarding the staging workup, because initially because this perihemangiopericytoma is usually considered as a brain lesion. So at that particular time, usually the staging workup doesn't include actually the CT scan just abdominal pelvis, but once it transform into the solitary fibrous tumor or to translate into the recent classification of solitary fibrous tumor, because solitary fibrous tumor is also may present in other part of the body as well. So that is why it is very important to first differentiate whether it is truly a primary CNS involvement type of solitary fibrous tumor, or it is whether truly a primary lesion or is this secondary. Because in our experiences, we have seen patients who have solitary fibrous tumor other part of the body as well, and then they have presented with the CNS. Even the patient who has first presented a solitary fibrous tumor, but on staging will come forward to have disease in other part of the body as well. That also biopsy proven solitary fibrous tumor. So that is very important for such cases. If we are proceeding with any intervention, before that we need to actually have a staging workup incorporated so that we have a better management plan. Or we can consider afterward if it turns out to be a solitary fibrous tumor.
Dr. Riaz Raja has raised his hand. He is a neurosurgeon and also the current president of our Neurosurgery Society. Thank you, Dr. Riaz, for joining us.
Thank you. Assalamu alaikum to everyone. And I just joined a little bit late because of some my problem. And my question is that I didn't join in the early, and I don't know about the CT and everything about imaging of that case. But my question to oncologists is that now is there any trend of changing from the conventional radiotherapy to gamma or the cyberknife? Or my second question is that is there a availability of the LINAC in the Pakistan and in which centers? And is the LINAC is more safer regarding the complications compared to the conventional radiotherapy?
Yeah, nowadays most of the brain radiation is done with linear accelerators. इसमें gamma knife और उसका कोई रोल नहीं है, वो अब थोड़ा देर पहले हम डिस्कस कर चुके थे, बिकॉज वेरी it's normally given to very small tumors, metastatic tumors or recurrent brain tumors which are very small, less than 3 centimeter or 3 centimeter tak. For big tumors like this, if we need IMRT or we need rapid arc, uh, clinic based, or and we mark the organ at risk. इसमें ऑर्बिट्स आ जाते हैं, ऑप्टिक नर्व्स, ऑप्टिक क्याज्मा, ब्रेन स्टेम, ये सारी चीज़ें, और उसकी फिर हम डोज कंस्ट्रेंट्स देते हैं. सो दैट इज नॉट पॉसिबल विद cyber knife or gamma knife. So in cases like this, most of the brain tumors that are pretty big, they would not need stereotactic cyber knife type or gamma radiation. Only conventional radiation, and the dose is 54 to 60 gray, and depending, and we would normally use 1.8 gray per day radiation dose.
And I was asking about the complications.
कॉम्प्लिकेशंस तब अब इसमें कि इफ़ यू मेक प्रॉपर, आप इसकी जो ऑर्गन एट रिस्क को आप बार कर दें और उनको आप डोज एक्सीड ना करें. सो बेसिकली हमारे डोजेस के साथ द चांसेस ऑफ लेट ब्रेन नेक्रोसिस बड़ी कम होती हैं, अनटिल अनलेस आप बगैर प्लानिंग के रेडिएशन दे दें, उसमें चांसेस ज़्यादा होती हैं. लेकिन अब तो वो नहीं, अब तो हम पूरा ब्रेन बनाते हैं, उसमें फिर ईच एंड एवरी ऑर्गन इन द ब्रेन इज़ जो इम्पोर्टेंट है, जहाँ पे डोज कंस्ट्रेंट्स होती हैं, जो हमारी रेडिकल डोज है उससे जो जो ऑर्गन कम टॉलरेट करते हैं हम उसको मार करते हैं, ताकि उसको वो डोज ना जाए जो हमारी डोज एक्चुअली ट्यूमर को जानी है. सो इस तरीके से कॉम्प्लिकेशन नहीं होती. लेकिन अगर ये कन्वेंशनल से प्लान किया जाए, कन्वेंशनल सीटी सिमुलेटर के साथ और उस तरीके से, तो उसमें कॉम्प्लिकेशंस का बहुत हाई रिस्क होता है, बिकॉज यू डोंट नो what where the doses are giving. अब तो minutely each and optic nerve का पूरा from eyeball plate to optic chiasma तक हम उसको मार्क करते हैं, और हर चीज़ की हम डोज को देखते हैं. और जब प्लानिंग होती है मल्टीपल फील्ड के साथ या आर्क थेरेपीज के साथ, सो वी मेक श्योर कि हमारे जो ऑर्गन एट रिस्क हमने मार्क किए हुए हैं वो डोज एक्सीड ना करें. जो टॉलरेंस है 50 ग्रे of the optic nerve या 54 gray of the optic chiasma या brain stem, उससे exceed ना करें. So complications are less, but the complication are always there with non-planning techniques जब यूज होती हैं. कुछ सेंटर्स में पाकिस्तान में उसमें हो सकती हैं डेफिनेटली. और द मोस्ट कॉमन कॉम्प्लिकेशन इसमें जो है वो एक्यूट में, तो वो आपको पता है कि देयर विल बी हेयर लॉस अगर उसका होगा. सेकेंडली डीमा हो सकता है रेडिएशन से, जिसमें नाउजिया वॉमिटिंग वगैरह हो सकती है, जिसको हम स्टीरॉयड से कम कंट्रोल करते हैं. लेट अफेक्ट में फिर ब्रेन नेक्रोसिस होता है, विच इज़ वेरी डिफिकल्ट टू डायग्नोज व्हेन पेशेंट्स आर ऑन फॉलोअप. और फिर उसके लिए हम MRIs वगैरह करते हैं परफ्यूजन देखने के लिए कि नेक्रोसिस और रिकरेंट, तो ये कॉम्प्लिकेशन है. लेकिन द चांसेस ऑफ दीज कॉम्प्लिकेशन इज़ वेरी वेरी रेयर when you properly plan and you check your doses before starting radiation to each and every part of the brain.
So I just want,
Okay.
I just like to add some more thing. Okay, I think Dr. Shayan has raised her hand. So we take the question from Dr. Shayan and then I can add.
जी अस्सलाम वालेकुम सॉरी आई जॉइन अ बिट लेट आई हैव क्वेश्चन फ्रॉम डॉक्टर आसिम ओनली you talked about primary and secondary solitary fibrous tumors. So like in cases of if we see that there is a secondary involvement, will it change the line of management, like surgery followed by RT? And how would you treat the secondary tumors? Like, what about the tumors in the other systemic region?
So, Dr. Shayan, very good question. Okay, is there a difference if we are treating the primary solitary fibrous tumor? Is there a difference in terms of treatment from the primary versus secondary? So, if we are talking about a secondary fibrous solitary fibrous tumor that went into the brain from some other places, then definitely our intent would be changed. And in that situation, it depends upon the doses that has been used for radiation therapy to the brain. So it all depends upon the other features as well. For example, if it is already a known case of solitary fibrous tumor and there is no evidence of disease elsewhere in the body on the staging overlap, and this is the only site, then definitely we can go with the higher doses to actually consolidate that particular area. But if there is a widespread disease present at the other part of the body, that definitely needs to be addressed according to that particular situation. And in that particular, I think Dr. Mazhar would be the right person to answer with the role of any systemic treatment in particular test scenario in which you get found the other lesion as well in the body as well.
अब डिपेंड करता है कि मतलब अगर ऐसी जगह पे डिजीज ये है कि उसको रिसेट किया जा सकता है, डेफिनेटली रिसेक्शन वुड बी द ट्रीटमेंट ऑफ चॉइस, एंड देन ऑन हिस्टोलॉजी उसके आगे फिर जो एडजुवेंट ट्रीटमेंट होगी इन फॉर्म ऑफ रेडिएशन व्हाटएवर दैट कैन बी गिवन. बट फाइब्रस ट्यूमर्स में आई डोंट थिंक कीमोथेरेपी हैज एनी रोल.
I just would like to add the previous discussion regarding the stereotactic radiation therapy. So one thing is that as mentioned by Dr. Mazhar and Dr. Muhib also, that stereotactic is a specialized technique in which we are using the very high doses of radiation therapy to a small volume of brain with a different radiobiological mechanism of destroying that thing. So traditionally, the stereotactic radiation therapy delivered whether so we are normally hear different terms, for example, cyber knife, gamma knife, or Linux. So all these machines are capable of doing or offering stereotactic radiation therapy. It is only the brand name that is associated with the stereotactic. All these things do. Some machines are very dedicated. For example, gamma knife for particular for the brain lesion, and similarly, the cyber knife is particularly designed for the stereotactic radiation therapy. But you can found a lot of literature and established practice all over the world where use that there is a Linux-based stereotactic radiation therapy. A majority of the setting also utilize the Linux-based stereotactic radiation therapy. So it doesn't mean that one cannot actually, it is only the cyber knife or the gamma knife that has been utilized for stereotactic radiation therapy. Linux-based stereotactic radiation therapy is a well-established thing. It has been present for decades. So this is one of the important thing. The other thing is that because the mechanism of radiobiology, of the mechanism of action of radiation therapy is different from in the conventional process stereotactic radiation therapy. So the challenges or the complication would also be happen accordingly. Because when we're using very high doses of the radiation therapy, that's why we are trying to limit our volume as much as possible, and also trying to actually keep ourselves away from the critical structure, because though the dose is small, but the radiobiological effect is much higher as compared to the conventional radiation therapy. So the small dose could lead to the toxicity that is undesirable. Regarding the conventional radiation therapy is established for almost a century, and there's a lot of data regarding the toxicity of conventional radiation therapy, whether in the form of IMRT, VMAT, or simply 3D conformal radiation therapy. So the doses that has been utilized for conventional radiation therapy has a very good, toxicity profile, or hardly normally the dose prescribed the toxicity has less than 5% or less. Or in the modern setting, one can say it about 1 to 2%. So that's why it is very important to have the discussion like this in this platform, so that we have given awareness and answer the question that is required to for the better improvement of